Good evening, everyone. So the topic allotted to me is actually quite vast, and it's an evolving topic, which is looking at biomarkers for predicting efficacy of immunotherapy which is not actually what we use in routine clinical practice, that is excluding PD-L1, MSI, and TMB. We know that in our routine clinical practice, PD-L1 is one of the most common marker used, and MSI is also being used increasingly. TMB, there is less robust evidence, but it is also an established tumor marker. However, there are multiple other tumor markers that are, or biomarkers rather than tumor markers, biomarkers that may indicate or impact indicate on outcomes with immunotherapy that also may be prognostic or predictive. So let's look at what are the non-PD-L1 or MSI TMB biomarkers. They can be divided broadly into ones which are within the tumor and the tumor microenvironment, and the ones in the blood, and some within the host like the microbiome, and other biomarkers such as genetic mutations. So we are always looking for better biomarkers to define or refine the population in which immune checkpoint inhibitors are going to benefit the most, because we know that they do have a substantial benefit in certain patients, and there are certain patients who do not respond to it. So like I already mentioned, within the tumor, genetic mutations, PD-L1 expression, TMB and MSI, also the neoantigen load, which makes certain tumors with mutations such as POL have a lot of neoantigens and better responders to immune checkpoint inhibitors. The tumor microenvironment is something that is evolving, which is one of the major determinants of outcomes, but is a little difficult to use in routine clinical practice. But the tumor infiltrating lymphocytes are one of the evolving biomarkers. Of course, circulating factors such as the myeloid cells, eosinophils, ratios of neutrophil to lymphocytes, and other cytokine proteins, and host factors, the most important, and which is coming up not just as a predictive biomarker, but also as one of the factors that can be targeted or modified to improve outcomes to immune checkpoint inhibitors. So I'll quickly move through. This is a vast topic, so I've just touched upon certain important parts because of the therapeutic implications. So let's look at biomarkers in the tumor microenvironment, and the most common are the TILs, or the T-infiltrating lymphocytes. So we know that we have different populations of T cells in the body, which again infiltrate tumors, the CD8 cytotoxic cells, the CD4 cells, and then we have the Treg and the memory T lymphocytes. And like we all know, the functions of these cells are different, and they have different roles in maintaining the homeostasis. So we know that CD8 cells directly kill the tumor cells by their cytotoxic effect, and the PD-L1 is one of the systems that we exploit to get therapeutic responses. But we know that this activity of these CD8 cells are regulated by CD4, by the various cytokines that this generate, which lead to cytokines that may activate these CD8 cells or inhibit them, and the Tregs. These mechanisms are basically placed to maintain an immune homeostasis, but in tumor cells or tumor microenvironment may have factors that step up the immunosuppressive microenvironment with the increase in immunosuppressive subsets of these T cells. So the most robust prognostic TIL marker that we have till now is the CD8 T cell. The CD4 is still no conclusive results on how we can use it as a prognostic marker or a predictive marker, but the T8 subset have some studies which show improved survival. The CD8 T cell infiltration within the stroma of the tumor has been correlated in multiple studies with patient survival. And also Treg cells, which are immunosuppressive or they are immune modulatory, have, especially the ones which express the FOXP3 transcription factor, have data to suggest that they may have poorer outcomes in non-small cell lung cancer. So again, refining these TILs and combining them with known biomarkers in non-small cell lung cancer, there is data to suggest that when we look at the TIL population along with the PD-L1 expression, we get an idea about the microenvironment and how immunosuppressive it is. So we know that patients who have CD8 low population, that was very low CD8 TILs and PD-L1 positive, that is PD-L1 is a T cell inhibitory receptor. So these had the worst outcomes, whereas the opposite, that is CD8 TILs higher with a PD-L1 negative, had better outcomes. So there is a definite prognostic and a predictive value to tumor infiltrating lymphocytes. The most important subset that we have data for is CD8 positive cells, and combining them with other biomarkers may be more robust. But there's a big challenge with evaluating TILs for clinical practice. One is directly measuring TILs is difficult. It is the studies which I showed you did it as IHCs on tissues. Also, when we generally biopsy a patient with lung cancer, it's a small biopsy in advanced disease and only rarely resected specimens where we'll be looking at these TILs for immune checkpoints. So basically trying to replicate or trying to understand the microenvironment from a small biopsy is difficult, and it is very difficult to basically get meaningful data to use in clinical practice from these biopsies. Radiomics is evolving, looking at immune infiltrator signatures, and maybe in future be a useful tool to identify patients who might benefit, but it's not yet widely validated. So the next thing I will briefly touch about is the neutrophil lymphocyte ratio, which has shown to correlate with the outcomes with immune checkpoint inhibitors. We know that neutrophils can lead to immune environment which has a lot of inflammatory markers which can cause a relative dysfunction of lymphocytes. Basically, with these cytokines, there can be activation of certain transcription factors leading to tumor growth, as well as a relative lymphopenia or a dysfunction in lymphocytes. And this has been seen in various studies in different settings, that is in advanced setting lung cancer, in early stage lung cancer, and in locally advanced lung cancer. And what the summary is that if you have a higher neutrophil to lymphocyte ratio, these patients do worse as compared to those who have a lower neutrophil to lymphocyte ratio, that is a relative lymphopenia in comparison to neutrophils is detrimental. However, this is dynamic, and what studies have shown is if there is a change in this ratio during immune checkpoint therapy, then these patients tend to respond better than those who do not have this kind of reversal of the neutrophil lymphocyte ratio. Again, it's something which we don't routinely use, but there have been certain, there's an index which has been developed on this ratio, which is a LIPI, or the Lung Immune Prognostic Index, which use two markers, that is the LDH and this neutrophil lymphocyte ratio, to classify it into good, intermediate, and low. The cutoff was 3, so they looked at a neutrophil lymphocyte ratio of more than 3 and an LDH above upper limit of normal. If both the adverse prognostic markers, that is NLR of more than 3 and upper limit of normal, the LDH, it was poor, and these patients had a poor survival of around 5 months, whereas the good group was the ones who had a ratio of less than 3 and normal LDH, and these went up to around 16 to 17 months. So definitely soluble cytokines and markers in the blood also are potential immune biomarkers. It is just that we have a lot of laboratory studies, retrospective and observational data, but little data from prospective randomized studies, but it is an evolving biomarker. Some of the tumors have mutations, and we know for all the driver mutation positive cancers, we already have data to suggest that certain co-mutations with EGFR or ALK, for example TP53, which definitely leads to worse outcomes in certain TP53 mutations when they are co-mutated. So similarly, we also have data for KRAS and STK11, and these are also potential biomarkers for basically immunotherapy outcomes. I'm not going to go through them because we're short of time, but poly mutations, again, a favorable biomarker for immunotherapy. KRAS and STK occurring together, a negative prognostic biomarker for immunotherapy. PTEN inactivation again has been linked to poor survivals. The data for lung has to be elucidated a little more. And TP53 again has worse outcomes. The most important is host determinants to immunotherapy, which include the microbiome, metabolic status such as diabetes or other factors, and also use of antibiotics and steroids. And this is one of the most important biomarkers that is evolving, and it is a therapeutic target. Basically, microbiome is just the organisms within our body which is known to basically influence our innate and adaptive immune response even in the absence of cancer. And this basically regulates our immunity with the crosstalk of the immune cells in the mucosa. And this microbiome tends to become, there is dysbiosis, and this can tend to influence our response of our immune system to further immune checkpoint inhibitors. So this looks like a busy slide, but it is just showing you the interaction between the CD8 T cell and the tumor and the T lymphocytes here and the antigen presenting cells and all the other factors that that influence outcomes, including all the bacteria in blue, which are actually beneficial microbiotic bacteria from various studies, and the ones in red, which bacteroideals, which is a one which causes expansion of the Tregs and worse immune responses. So quickly, since we have no time, there has been a correlation with the bacteria noted in the gut as well as in the lung and upcoming in other things such as saliva. And I think, slides band kar diye, okay. So basically, these are three species that were seen in various studies, the Archmansia, the Faecalibacterium, and the Bifidobacterium. Lot of studies, many of them retrospective, but you can see the recurrent species which are seen in responders, which are believed to have a better or induce a better immune microenvironment or a better immune milieu for immune checkpoint inhibitors to act. And this is one of the recurring bacteria which is seen across the board in RCC, NSCLC, which tends to have a good prognostic impact, and it is seen more in responders. So these are the gut microbiome, certain metabolites as a result of these bacteria causing the short chain fatty acid production and other metabolites that are produced because of the activity of these bacteria, and certain bacteria in the lung which previously was thought to be sterile, but we know it has its own microbiome, which are supposed to be having a immune inflamed kind of microenvironment in the body and allows our immune system to have better responses with immune checkpoint inhibitors, and those which have negative correlation with responses in immunotherapy. Again, just a note on lung microbiome. Lung microbiome is a very new biomarker. It is evolving. There are very small studies which show that certain bacteria, for example, this Veillonella, have adverse impact on immune checkpoint inhibitors and are seen more in non-responders. So how do we modulate? And this is what is the most interesting part about these non-PD-L1 and TMB microbiolators, is that microbiome can be modulated. There is a lot of studies going on for fecal microbiota transplantation, probiotics, prebiotics, and dietary modifications. These are the retrospective studies that initially got the data to show that probiotic use of certain probiotics might impact not just the outcomes, but even immune-mediated adverse events. And now there are formal prospective studies evaluating particular bacteria which are supposed to be a pro-immune response bacteria in combination with other therapies to look at the outcomes in lung cancer. We already have published data for Nivo-IP in renal cell carcinoma which showed probiotics improved outcomes. And this is one of the most exciting and promising fields for target in multiple tumors. Some limitations we all know of all these things. Definitely TIL's standardization is not there, it is technically difficult. NLR is also subject to standardization. Signaling pathways, there are multiple crosstalks, it may vary from cancer to cancer. Gut microbiota, is a lot of understanding that we yet need to have, and influenced by diet, antibiotic, race, proton pump inhibitors, and multiple things. Radiomics I have not touched upon, but radiomics is evolving. It needs validation, but in the future, the radiological pattern using AI of tumors will help us to understand which are the tumors which have an immune signature which will predict responses to immune checkpoint inhibitors. But this needs a lot of work. So we have a lot of evolving biomarkers for immunotherapy beyond what we use today. They are going to come up in a large way. Some are limited by technicalities of doing them in clinical practice, but others have predictive, and of course, they give us potential for novel therapeutic targets like the microbiome. Thank you.